Hi guys, so today we are going to learn some very important points that you must know about ECG because that is what is going to help you in clinical situation when someone asks you to read an ECG. So let's begin. Must know ECG basics. So in a case of MI, when the and you check for ECG, the ST has become normal, but the T wave and the Q wave, as shown here, are still prominent. It has been more than 24 hours. Let's understand the blood supply. So this is the left ventricle. Anterior is supplied by septal branch of the left ascending, left anterior descending branch. Lateral is by left circumflex and left anterior descending or lateral diagonal. And that's your lateral wall. And then coming to inferior wall is by your right coronary artery, more commonly compared to left circumflex, and then posterior wall is by left circumflex only. So that is the supply, blood supply. Coming to leads. So V1 and V2 or V3 and V4 is the interventricular septum. V1 to V4 is your anterior wall. 1 AVL is your upper half of the lateral wall. V5, V6 is the lower half of the lateral wall. V1 to V6 and 2, 3 AVF, 1 AVF together is the complete lateral wall. V1 to V6 is anterior plus lower lateral wall. 2, 3 AVF is inferior wall. 1 AVF is upper lateral wall of left ventricle. Then V3 and V4 in the right leads. V4 is more sensitive. Remember the larger number, so more sensitive is your right ventricle. So lead 2 will better show the blood supply for left circumflex and 3 is for right coronary artery. Transmural infarct will always have reciprocal changes, that is depression in the opposite leads. For example, if there is a elevation in 1 AVL, then you can see a reciprocal change in the inferior wall, that is 2-3 AVF. And if it is infarction in the inferior wall, then the reciprocal changes will be seen in the lateral wall. Coming to rhythms and rates. So heart rate less than 60 is your bradyarrhythmia and more than 100 is your tachyarrhythmia. You will first check the RR, then the PR and then the PP interval. So first you will check the RR, then PR and then the PP interval. If everything is constant, that's normal. If PR is more than 0.2, then it is the primary heart block, prolonged PR. After checking RR, you check PR, which is irregular, but PP again is constant. But PR is not constant. So in that case, if PR is elongating with every beat and then you get a skipped beat, then it's a Mobitz type 1. But RR remain constant and then there is a skipped beat, then it's a Mobitz type 2 heart block. PR interval should be between 3 to 5 small boxes. If it is more than that, PR interval should be 3 to 5 small boxes. And let's see what is the PR. So this is your P wave, Q, R, S and T. So this is P, Q, R, S. So this interval is 3 to 5 small boxes. Now, if it is more than 0.2 seconds, that is more than 5 small boxes, then it's your primary heart block. And if it is less than 0.008 seconds, then it is WPW syndrome, that is less than 3 boxes. So 3 to 5 small boxes that you have to remember. Next thing you check is for the QRS height in the chest leads and the limb leads. In the chest leads, you will see for deviation of 2 big boxes, and in the limb leads for 1 big boxes. If they are less than that, so the limb leads should be within 1 big box and the chest lead should be within 2 big boxes. But if they are less than that, then it is a low electrical impulse, low complexes, that is seen in cardiac tamponade. Coming to width, so normally the QRS complex width is 2 to 3 small boxes. If it is less than 2 small box, it is arrhythmias, and if it is more than 3 small box, it is a bundle branch block. Rhythm. P wave is present and it's regular, then it is sinus arrhythmia. P wave is absent, then it is atrial fibrillation. Now tachycardia, as we saw here, it was the rate more than 100. But if any time the rate is more than 180, then it cannot be a sinus tachycardia. There should be an ectopic source. So tachycardia, you first see V1 lead. In V1 lead, if the complexes are broad, which means ventricular origin, and there is no P waves. Let's see if they are regular. If they are regular, then it is a ventricular tachycardia or a supraventricular tachycardia with a bundle branch block. If it is irregular, then it has been converted to a VFib. It could be paroxysmal supraventricular tachycardia or torsades pointus. That is the sine wave. Narrow. The QRS complex is narrow when it is less than 3 small boxes. If it is an irregular narrow and you don't find a P wave, then you are thinking about atrial fibrillation. But if it's regular and P wave is present or absent, you will check that. If P wave is present, sawtooth pattern, then it's your atrial flutter. If P wave is absent, then it's a supraventricular tachycardia. Most common is AV node reentrant tachycardia. Then you see V1 QRS complex. Is it a positive deviation or it's a negative deviation? If it is a positive deviation, then it's a right side pathology. Remember, being positive is always right. So positive deviation in V1 is your right side pathology. If the complex is broad, then it is a right bundle branch block. If it is a narrow complex, then it is a right ventricular hypertrophy. Then you see in V1, the complexes are negative. Then it is a left side pathology. If the complex is broad, then it is a left bundle branch block. If it is a narrow or it is normal, then it could be left ventricular hypertrophy, and you have to fulfill the Lyon's criteria. So what is the criteria? S in V1 and R in V6 has to be more than 7 big boxes. If this is not present, then you can say the ECG is normal. Coming to ST deviation. In the limb leads and in the chest leads, limb leads is 1 mm deviation, chest leads is 2 mm deviation. So it could be elevation or it could be suppression or depression. Elevation means transmural infarction. Depression is only ischemia, not transmural infarct. Half hour. If if the infarct was within half hour, you will be seeing hyperacute T waves then. And if it is 1 hour, then you will see ST elevation. So this is a window where you can give thrombolysis. As long as the T waves are erect, you can give thrombolysis. When they become inverted, then you cannot. After 12 hours of the infarct, the ST elevation will become dome shaped, and there will be T wave inversion, which is known as queuing pattern, and you cannot give thrombolysis as soon as the T wave is inverted. And then we will just revise what we learned in the very beginning of the 24 hours finding. The ST will go back to normal. T wave and Q wave will be prominent, suggesting an old infarct. Okay. So that's all. Must know ECG facts. Listen to this video for a couple of times and you will be knowing them by heart. Thank you.